I'm Jessica Wilson, and you're listening to Making It Awkward. Welcome to the first episode of 2024. Today's episode is my conversation with Shantille Connolly, a senior health promotion specialist at UC Davis. We talk about our process of instituting a policy to make being weighed an opt-in measure at the clinic rather than a default, and only required for things like medication dosage that is based on weight. I left Davis a year and a half ago, and in this episode, she will fill me in on the progress of the policy and share the feedback she's gotten from patients there. Now, listeners may have experience with going to the doctor for something like an elbow sprain, and instead of talking about that, the conversation veers into weight loss recommendations and discussion of BMI. If you've listened to the last episode about how my body was treated by my doctors as a kid, you'll have a good idea of how a focus on weight can play out for kiddos. All of this led Shantille and I to exploring weight stigma on the UC Davis campus. And in the spirit of what's in and what's out for 2024, I will say that I still have epilepsy and rely on multiple medications a day to make my brain function to the degree that it's able. Amongst ongoing proclamations that food is medicine, but only the correct food, and the idea that people who take medication have somehow failed to cure ourselves naturally, shaming the use of medications is out for 2024. For those of you who feel shame for taking medication or who want to but aren't able to work through the stigma attached, hopefully 2024 can be the year you lean into what you need. I'll also propose that food as medicine is out for 2024, and we let food be food and medicine be medicine. For what is in, friend of the podcast, Clara Nozick, has let us know that boofing is in as one of the wellness trends for 2024. Boofing, sometimes referred to as booty bumping or butt chugging, is the practice of inserting a substance into your butt in order to speed up absorption. People have done this with alcohol and drugs for decades, but now it's wellness's turn to start boofing coffee and ozone. I was first introduced to the concept of boofing a decade ago, yet I didn't know it was called boofing then. I just thought it was a different type of enema. A family member of a friend would boof coffee grounds every morning as part of her alternative medicine routine, which, fine, you do you. She would then also spend tens of minutes every time I saw her talking about how addicted people are to caffeine and how she would never want to be so dependent on espresso to function. This was also how I learned that those red hot water bags that people use as heating pads are actually enema bags. I know, right? This person's dissonance was deeply annoying and at the same time felt aligned with the tendency of wellness communities to demonize certain foods, like cow milk, while at the same time adding cow colostrum and collagen to their post-workout recovery drinks, or telling us not to eat anything I wouldn't have found in my grandmother's cabinet, but then ordering a Hailey Bieber skin smoothie with hyaluronic acid and vanilla stevia added from Erewhon. In 2024, making blanket statements and shaming others' food choices is also out. And now, here's my chat with Shantille. Shantille, welcome to the show!
Thanks for having me. I'm super excited.
I'm so glad that we get to reconnect and do like a work-related thing. A year and a half? Yeah, later.
Yeah, I remember when I was just new in my position and you asked me, are you going to be here a long time? Because I don't want to start projects if you're going to leave. And I was like, I'm going to be here a long time.
You really convinced me. You said that this has better healthcare and you wanted to have kids. So
yeah, here I am. With 2 sick kids at home.
So I was like, okay, Shantille's really going to be here. So yeah. So then we got to work on projects and then I was the one that left. Anyhow, back to us.
And now we're back together.
I know, it's true. We're going to keep doing stuff like this. Let's get started and talk about how we ended up doing the weight stigma research initially.
Yeah, so we were on a committee, of course, lots of committees, and we were looking at why students weren't coming to student health and counseling services and campus recreation. So all students have access to these services. They pay fees for these services, but we know that at least half of our students don't utilize our services. And so we wanted to know why. The research suggests that weight stigma is present in healthcare and recreational, gym settings. So we assume that it's likely the case here too. And so we started to, just ponder why, or how weight stigma was presenting itself at our health center and the gym as well. And we started doing focus groups to better understand what the barriers were for students.
Mm-hmm. And I think we had maybe 7 and 4 people in those initial focus groups, which was great because it helped us, narrow down our poll, our survey that we were going to end up doing. And then do you want to explain what happened next?
Yeah, so we did the focus groups, and I feel like we learned more than we expected to learn in the focus groups, and it made us start questioning so many other things as well. And we're like, we want to learn from more students, but we didn't have the time to keep leading focus groups. And so we turned the focus group into a qualitative survey and just kind of sent it out into the ether. This was the first summer of COVID, and we didn't know how students would, react or respond. And we're definitely unprepared to get the number of responses we received. I think our sample size was about 2,500. And it was all free response. So some students left paragraph responses. And we had one PhD student actually tell us it went viral on social media because students were just sharing the post we put up on our Instagram to tell other students to complete it, which literally never happens. So that was super surprising.
So after we had our 2,500 responses, I remember because it was that first few months of COVID where, I was just happy to have a job at that point. I printed out all of our responses and then got out color pencils, crayons, and just trying to come up with themes. We also, do you want to explain the body scale situation that we used to narrow our research?
Yeah, so we used the Skunkard figure size rating scale. I think it was 1 to 7?
1 to 9.
1 to 9. And it showed various body sizes. And we asked students to identify with their body size by rating 1 to 9. And then that allowed us to look at our target audience, which we identified was body size 7 to 9. And we could look just at their responses, but we ended up looking at all the responses overall because everyone had something to say about weight stigma on campus. But that really helped us narrow down our focus.
Yeah. We did narrow from the 7 to 9, but it was really basically everyone who said that they, avoided going to the doctor because they were afraid of, talking about their weight. It really wasn't so different as far as barriers were concerned. It was interesting.
Yeah, or even I remember reading a lot from students, even in like the 1 to 5 category, saying just how they saw too how it affected their peers, especially in the classroom setting, which I'm sure we'll talk about later. And how they wanted to be advocates for it too, because they saw how others were affected by it. It was very, very apparent to them.
And I also remember how smart our students were overall, and honestly smarter than a lot of stakeholders and colleagues of ours, mentioning where BMI comes from, how it's embedded in white supremacy. Just go read Fearing the Black Body by Dr. Sabrina Strings. And knowing so much more really than the people they were going to be seeing in the doctor's office, which was an interesting juxtaposition for me there.
Yeah, it was very apparent that the student, I think our question was just what do you think about BMI? And it was very apparent that students had very negative outlook on BMI and also knew the history of BMI, which I feel like is not necessarily something you always find in the healthcare field too. They were coming in to see our healthcare providers already having a whole education on BMI and its roots and its problems as well.
And then having to sit there and have a doctor, talk about BMI as if it were a real thing, is something that I hear even today. Like, oh, you believe that BMI is real or all these things. Definitely. So we got that. I put together a report. It was like the biggest brain stretch before I had written a book to put all of those words onto paper. It was pretty good. I was really happy again just to have a job that year, and created that work for myself. But then you did like the most amazing job. It really came to light that we all brought our own strengths, because then you went and rounded up everyone on campus to be on board.
One of the topics I've worked on in my time here at Health Education Promotion that campus partners have been most excited about change for. And like, I feel like a lot of my job, I'm just convincing people constantly that we need to change something or be proactive about something, do something for prevention. A lot of convincing, but when we brought the data to our campus partners, I can't think of many instances where I really felt like we had to do convincing. And I think it's because the data itself did a lot of convincing. Like the student narratives were so powerful that our campus partners read it and were like, yeah, we can't ignore this. Like we got to do something about this. And that's always really stuck out to me about this project. So I feel like so many times we say, like, well, 25% of students experience this. And like 1 in 4, that's a lot. But it's hard to really connect with that until you get a student telling us exactly what happened when they went to go to class and couldn't find a seat and the way it made them feel. So I feel like those responses were so powerful and really helped our campus kind of rally around this effort.
Yeah. The facilities-based stuff was, the like questions that we weren't going to ask until we had done those focus groups. And I think those ones indeed had the most probably impact on reception of this survey.
We didn't even ask a question about the classroom on our first survey. We just said, like, are there any other concerns? And then I'd say at least half of the responses mentioned the classrooms. I remember one response was like, I can't believe this freaking survey forgot to mention the classrooms. Like they are awful. They're not size inclusive. So that led us on to like an even larger path to navigate the physical structure of campus.
Right. The comments like, I can't, sit down in these chairs. I pay to go to school here. I can't put the arm down. I'm writing this exam on my lap while trying to balance like my paper and my calculator and all of these things. And then also teachers chiming in with like, they can't get down rows to answer questions. So if students have questions, they have to save them all until the end. And it just ended up being this like snowball of like, oh, everybody has been experiencing these things, but now we are having like a bigger conversation about it.
And I also remember reading about students who the anxiety they felt before even getting to a class, or if they were going to be late to class and they just like wouldn't go to class because they knew that they couldn't find a seat. And so imagine like you're already stressed about, midterms and life and finances, and then having to navigate like, I'm going to be late to this class. There's not going to be a seat available for me. So I'm not going to go to class. And then in that other survey we did about the barriers to seating and mental health, then students talked about, well, if I don't go to class because of the seating that doesn't accommodate my body size, then I get stressed out about the classes I missed. And then that negatively impacts my academics as well. And so it's just like this cascading sort of snowball that just like, keeps going down. And I think when facilities did come up with additional money to renovate the classrooms, like that just doesn't happen on campus. People don't just like have extra money to throw at something. But I think it showed that like they really recognize the need to, see it as an issue and want to put resources into it as well. Our resources are limited, but the fact that they were like, we will match the funding you got from that grant to do another classroom, I think shows that like people do know this is a huge problem on our campus.
Yeah. So we got facilities first. And I think at that first meeting that we met with facilities, they said, oh yeah, why don't we write this into a policy that, it needs to be like this weight limit and like this depth and height, etc. And you and I in healthcare, it takes 5 years for policy. We're like, that's it. Like you're going to do this. And I think that in and of itself helped with other departments because we're like, well, facilities already writing this in. What are you all doing?
What are you doing now? Yeah.
Yeah.
Absolutely. Yeah. It's so hard to get policies to change on campus. And they were so proactive about it. And now like the teaching and learning complex, the seats in there completely align with those policies. And I hear students now talking about it, like, I only like taking classes that are in that building because I know I can go and find a chair that fits my body and be comfortable in class and like actually engage in the class and learn instead of being focused about how uncomfortable I am sitting here.
Yeah. And it is not even just like an updating of classrooms to make them like newer classrooms, because I went to Wellman, one of the, lecture halls on campus, and one of the ones that had just been redone, like I stood between like the chair and the one in front of me, and there was like a huge indentation on my butt from there. So it wasn't just like that they're putting more classrooms in. It really was the policy that helped out. So yeah, like a huge success and support there. How do you think the reception was at the health center on campus?
I think it was mixed. I think some people definitely were aware of it already, and the data just helped confirm what they already knew and were potentially hearing from students or providers. I think some other folks that like weight and health are so deeply rooted in healthcare that the data didn't necessarily matter to them. It didn't change what they thought. Luckily, folks in leadership roles were listening and were able to make some changes, and we're continuing to work on those changes. But I think also with Campus Rec, same thing, like in places where it's just so meshed into the culture of health to have like your weight taken in appointments, to have a scale in the locker room. Like it's really hard to get everyone in an organization on board with this.
I completely forgot about this until you just mentioned it. The saga of the locker room scale. When we started, the scale was at the like entrance, basically beginning of the locker room, and then it would stretch all the way back. And one of the responses to survey data, or all in this process, they moved it to the back of the locker room, and multiple times someone moved it to the front again, which is just so wild to me that whomever it was like needed it to be front and center or something.
Yeah, I mean, remember you had students sharing with you that like they would stop daily on their way.
Oh yeah, they would just go to the gym like on their way home, not to work out, but to step on the scale.
To step on the scale, yeah. And I do know it was a lot of pushback from community patrons that were using the gym about the scale. But it's also like doesn't support the messaging either to like come be active, feel good in your body, reduce your stress, improve your energy, sleep better, and there's a scale. So that continues.
Right. And you mentioned community patrons, and for those listening, like that's the like not students. The people who are paying to go there are the ones that were the most angry about the removal or moving of a scale, which is interesting that it ended up staying because the people who were paying like felt such a strong way when the gym is for students, but whatever, that's okay. Some of the feedback on the survey was directly responding to some things that the gym had done and programs that both of us had supported at the health center, which were, special areas or specific areas where people could go and feel, like safer working out, where they weren't as judged as much as in other areas. And then there was at least one, if not multiple people who responded and were like, why are you just like kicking fat people to, the smaller section rather than actually changing the environment? It was like, yep.
Great question.
Yeah.
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 Yeah, and for those folks too, the gym itself has like they call it the fishbowl, which is the huge area where a lot of the strength equipment is, and it's really intimidating. There's a lot of people in there. That's all glass windows on both sides, so you just like walk by and people looking at you. And so yeah, the idea was to create these nooks where people could kind of like do their own thing. Maybe they wanted to watch a video from their phone or just have a quieter space, but that's like it to some folks. It's like you're just telling us to go to another area instead of changing the entire gym environment.
Yeah, I know that you and I received that very well. I can't remember how others responded, but I feel like a lot of the feedback sometimes is like, well, what do you want us to do? Like, we've tried all these things. And, one thing that you and I have learned is that there isn't a quick fix. Like, this is not an Amazon Prime situation. This is more like we're building like an environment from the ground up, and stopping at the quick fixes where a lot of this like work then doesn't get done or get stuck. So yeah. And then I think it was a student of yours that approached you about declined away cards.
Yeah, they had seen them at a clinic in the Bay Area and were wondering if we could do something similar at our health center. And this was also like a pretty quick win in the grand scheme of things for like how long things can take in the university setting. We presented it to leadership. They were super supportive of having this card that students could show the MA that would allow them to not step on the scale or do a blind weight if a weight was needed for their appointment. And we got them designed, printed them out, and put them throughout the health center, and then also out to our campus partners as well in various student retention spaces as well.
I think it was relatively like fine to roll them out. Initially, it felt like there might be some problems, but as it got going, the MAs and support staff were just like, yeah, it's happening and it's okay. It's fine.
Yeah, it was. I didn't get much pushback at all, which I feel like people listening are probably like, does everyone disagree with everything you do?
Yes. Yes,
But no, not much pushback. And I think the biggest thing, though, was when we made the organizational change, which I don't know if you were here for that. So the cards were successful. Students were using them. People were telling us they were using them. We were collecting data and electronic records so I can look and see like how many students were declining away. And we had between like 10 and 15 or so for the first 2 quarters that we did this. And then we decided to not get rid of the cards, but we made an organizational change in that the MA, every time they bring a student back for an appointment, they just ask the patient, do you want to be weighed today? And when we did that in March of 2023, and we saw it went from 13 students the month before declined to be weighed to 137 that month. So it's like you took the pressure off of the patient to, give the MA the card. And also, like, not all students didn't know that was an option as well to have the card. So now you're not relying on them to come in with the awareness of this option. You're presenting them, when they come to their appointment, like, do you want to be weighed? Yes or no? And from there, it only increased. Like May, we had 330 students decline to be weighed.
Nice.
So last year, like all in all, we had almost 1,300 students decline to be weighed.
Nice.
And that also we didn't get much pushback from. I haven't heard from providers at all that it's impacted their patient care in a negative way. If a student if they do need a weight for an appointment, like let's say it's for a prescription that's weight based, they'll have the student and they didn't weigh before they came in the room. They'll have the student go out and do a blind weight and put it in their chart for the prescription. But it definitely has not negatively impacted patient care. I've gotten a lot of positive feedback from patients that they're really happy it exists and they're now more willing to come to the health center to have an appointment, knowing that they can decline to be weighed.
What's some of the feedback that you've gotten?
One student said, as someone who gets anxious at the idea of being weighed, I often fear or become nervous when I know I have a doctor's appointment. With this new option, I feel more comfortable seeking the resources provided by the school. And another student said, I stopped seeking care last year because I had to be weighed. I had disordered eating and being forced to take off my clothes, go to the bathroom, and then be weighed, put my clothes back on, and finally start my appointment made me so upset I felt dehumanized.
Mm-hmm.
I didn't know I could reject the weighing, and even after my doctor told me, I was so upset that I stopped making appointments. Thank you for implementing this.
Mm-hmm. Nice.
Yeah, so that was like a relatively easy change that we know increased access for patients.
Right. One of our first focus groups, I remember somebody saying, I have to make sure like my arm is like broken. Because if it's just like maybe broken, they'll just tell me to lose weight and use ibuprofen. So changing that has been like a huge win. And I think another important part of it was us keeping people informed. So when doing, follow-up surveys and stuff like that, rather than just asking for people to give us information like again and again, be like, this is what we're working on. This is why we're continuing to evaluate. And you put up a website where people can check out your progress, which I think is great.
Yeah, I try to have like really open line of communication with the MAs and like the MA supervisors, since they're the ones that are doing this too, to let them know like how positively it is impacting students, and to share like what we're doing next. Because I do think that to get buy-in to really like change the way a medical provider has been trained,
Mm-hmm.
it is like a really iterative process, and it requires a lot of teamwork and, going back and forth on things and sharing data to help support why we are doing these changes and what we're working towards.
Mm-hmm. I think something that was surprising for a lot of providers, everywhere to hear is that Sarah, the other dietitian who was working there, and I like didn't feel a reduction in our capacity to do our job as dietitians when we didn't have a weight on somebody. And it's just like, what kind of care am I providing, rather than not even just weight-based care, but like the stuff that I'm used to having on hand. But it was like, oh, this is like a person who hasn't been weighed. I'm going to care for them like any person who I'd be talking to.
Well, and I think that speaks to the suggestions that you and Sarah made too for changing the way we asked questions, or even changing questions entirely on intake forms too.
Mm-hmm.
Like, remember one of the first question a student saw was like, how satisfied are you with your weight, or something like
yes.
that. And it's like, why does that need to be a question, first of all? And why is that the first question they see when they're like getting ready to come in for an appointment?
Mm-hmm.
So I think, and after we changed those questions too, we didn't get any feedback from providers being like, I don't have the information I need to care for this patient now.
No. Once it was done, like that was, I think that's really what it comes down to a lot of times. Once it's done and people see like it didn't really make a difference is really important. But the conversations, well, this will tell me about X, Y, or Z thing, or I'll know like they want a referral. And it's just like, what is your actual care? And did you have even time to address that question? The idea of like taking something away from people is a lot of where we'll get resistance. But then once it's gone, it's like, yeah, we didn't need that anyhow.
Mm-hmm. I've been talking with another professional about who's like in the size inclusive healthcare space about how the back end, like how the electronic medical record itself creates weight stigma in like a provider patient relationship too, and the way that like questions are asked that the provider has to fill in, which isn't something that I've thought about either. So I think that's a really interesting path to go down as well. And that like may feel like, oh, we're taking away like how this template looks or changing the template.
Mm-hmm.
But then maybe once they see that, oh, I can still do this just the same, if not easier. And like maybe my patients enjoy, how I interact with them more with a different template. Like that could be beneficial too.
Yeah. One of the things at the clinic that I'm working at, ran into with all of this was just not having the workflow and capacity. So I think that is something that clinics can keep in mind when trying to do a more like compassionate policy and care is just really recognizing where the focus needs to be, because like going back out and getting reweighed when you put in a referral or you needed a wait, like those are things that we are able to do. And so if clinics are really looking at these policies rather than like trying to implement something first, my advice would be look at your workflow and if you have the capacity to do these things.
Mm-hmm.
And if not, like that's a great place to start for your clinic. But what's next for you and what are you working on?
So I've been getting a lot of questions from other colleagues at universities that are trying to do either a Decline to Weight initiative or starting to address weight stigma on their campuses. And I've been meeting with folks one-on-one, but realized it might be more helpful if we come together as a group. And so we started a weight stigma collective for college health professionals to get together, learn from each other, kind of like problem solve together and help us all, progress our work in this area. So that's been really exciting. We had over 25 people interested in it, our first round, and we're going to plan to meet quarterly and hopefully develop a white paper proposal to share with our national organization about college health centers and how we need to move towards a size inclusive approach. So that, and then also with our health center developing a size inclusive healthcare team. So even though we can, patients can decline to be weighed, that doesn't mean that weight isn't going to be brought up in their appointment.
Nice.
So
yeah.
How can we develop a team of providers that do want to practice size inclusive healthcare that patients can self-refer to so they know when they're seen at the center that they, weight won't be brought up in their appointment. They can go in for knee pain and won't be told to lose weight.
Right.
We just got approval to start working on that. So that's the next thing. And then back to the classrooms too. I did go into that Wellman classroom you were talking about and gave a presentation about weight stigma to a public health class. And one student had a great question, which was, there's so many classrooms on campus with this issue that we can't just overhaul all of them. But what can we do about like the current classrooms as they are? What are our options? So I want to explore that more too. And like, even if just being able to, for professors to recognize even on the first day of class, like, hey, I know this sucks. Like, I know the classroom situation sucks. Like, have an open relationship with me, to share, like, if you miss class because of this, like, let me know, or just to have more dialogue about it, and then work with other units on campus to see if there's short-term changes we can make. But I think if we can just have people recognize it so that students also don't feel so isolated in dealing with it too, that could be helpful. But yeah, when she asked that question, I hadn't really thought about that yet. So I've been so focused on like, okay, well, what's the next classroom we can renovate, or what's the next lecture hall being built? Like, how can we, change the seating there? So we have so many classrooms that exist though and aren't being changed. And what can we do about those ones as they are?
Yeah, I think in the early policy talks, it was like, let's take out, every other or third like chair or whatever it was. And it was like, sure, that gives like more leg room, but like the desks are still going to be there. That little thing that I'm going to try and get over on my lap. The size inclusive care team, I'm so excited. That one's new and totally goes to at least one of the students who gave feedback. It was like, even if you don't take my weight, like it's still like an anti-fat appointment. You're still going to talk to me because you can see the size that I am. I'm excited about that. I love that. I love what you're working on.
I've been consulting with Undermist Health on it. They have a huge size inclusive care team and are basically like my goal, just trying to be them at this point. But I think students will be really excited about it too, and just feel even more comfortable accessing our services if they know that they can come in and not expect to be told to lose weight.
Awesome. Thank you so much for your work and your time.
Thank you. It was so fun to chat with you again.
No, why don't we like talk when it's not just a podcast interview sometime?
That would be lovely.
Thanks again to Shantille for coming on the show. She's one of the few people who assure me that public health can actually be for the public. Next week, we'll begin some episodes about eating disorders. I'll talk with Angela Goins and Whitney Trotter of the BIPOC Eating Disorder Conference about their experiences as Black dietitians in the field. Things have been very awkward for them. Until next time, make it awkward. If you enjoyed this episode, you can rate it, review it, and follow the show for weekly episodes. You can email the show at makingitawkwardpod@gmail.com. This episode is sponsored by Whitney Trotter of Blessed City Health in Memphis, Tennessee, and the Legacy of Sacramento Outboard Services. It's a production of The Body Politic. I've been your host, Jessica Wilson. And just so we're clear, Jen Jacobs is what's in as a podcast editor and mixer for 2024.